3D anatomy model. So first layer, I'll be just showing you some of the layers, the muscles, because when we are doing the procedure blindly, we are palpating the bones. When you are doing under the CM, we are again seeing bones. So only with the ultrasound, you can see the different muscles and other soft tissues. So first, if you are removing the latissimus dorsi, so you are having the erector spinae group of muscles. So they are the two muscles. One is your longissimus, another is your iliocostalis. So if you are removing these two muscles, there is another erector spinae group muscle, that is your multifidus. Multifidus is more medial and little deeper to the longissimus. And if you are removing these muscles, then below that, what is coming? So multifidus also I am removing, and then we'll be having this transverse process. They are the transverse process. So if we are between the transverse process, we'll be having another muscle. We call it the intertransverse lateralis muscle. So intertransverse lateralis, and just beside that, we are having the quadratus lumborum muscles. And if we are removing all these things, then anterior to that, we'll be having the psoas muscle. So if we are looking about the spine, lateral to the spine, we are having the three important group of muscles. One is psoas muscle, psoas major minor, anterior to the transverse process. So this transverse process is very important. You know, the boundary. Anterior to the transverse process is your psoas. Lateral to the transverse process, this is your quadratus. And posterior to the transverse process, we are having erector spinae. Erector spinae means again three muscles, multifidus most medially, then your longissimus, then is your iliocostalis, they are the erector spinae. So three important group of muscles around which is almost covering the spine. And we are having some of the other ligaments. We'll be showing that later on. So parts of the vertebra. You all know these things. This is one of the vertebra. So what are the parts there? We are having, this is the superior articular process. This is your transverse process. This is your inferior articular process. This is your spinous process. This is your lamina. And in front, we are having the vertebral body. This is when we are looking from the posterior, from back. Then when you are looking from the side, lateral, we can call. So we are having the vertebral body. We are having the pedicle. This is a pedicle. This is the transverse process. But transverse process, we cannot see it nicely because we are seeing from the lateral side. And we are having the superior articular process. Superior articular process is very nicely seen. And inferior articular process, which is covered under the superior articular process. And spinous process. Again, spinous process is looking big because we are seeing from the lateral side. So, and these are some of the windows. Means if you want to enter inside the spinal canal, then we are having the several acoustic windows through which we can enter. One of them is in between the two spinous processes, we are having the interspinous space where there is supraspinous and interspinous ligament. Then puncturing those ligaments, we can go through and we can peep through the spinal canal through this space. Next important space is between the two lamina. So in between the two lamina, if you are holding the probe little bit, oriented towards medially, this is another very important space, interlaminar space. We can peep and we can see inside the spinal canal. Another important space where we can go through and we can see something is your transforaminal area between the two pedicles, and we can look through the foramen inside the spinal canal. Particularly when you are holding the probe from the lateral side through the foramen, we can see some of the structures inside the spinal canal. And another, which you normally don't do because it's very difficult, unless the patient is very lean and thin, you cannot see, that is anteriorly. If you are holding the probe anteriorly, and you can see the disc and you can see the spinal canal through the disc. So that is another approach, but it is very difficult. And unless the bowel is very nicely prepared, unless the patient is very lean and thin, you cannot go through anteriorly. But that is another acoustic window. So they are the four acoustic windows in between the two spinous processes, in between the lamina, through the foramen, and anteriorly through the disc. Then some ligaments are there. Supraspinous ligament in between the two spinous processes. Interspinous ligament is there also in between the two spinous processes. And we are having the ligamentum flavum, which we are puncturing, particularly the anesthesiologists are puncturing so much for the spinal epidural. So interspinous ligamentum flavum between the two lamina. And for the pain physician, another very important is your medial branch. So medial branch is a branch of dorsal rami. So now root when it is coming out, it gets divided into the ventral rami and dorsal rami. Dorsal rami again has three branch: medial branch, intermediate, and lateral branch. And medial branch comes through this groove. This is your transverse process. This is your superior process, and through which the median branch comes, and it accompanies a artery, and it is under the mammulo-accessory ligaments. So this is your mammillary process. This is your accessory process. So this black is your mammillary-accessory ligament, and this runs behind this. I'll be showing today that if seeing this artery, then it becomes very easy to block the medial branch here in this view. Then your intertransverse tissue complex. So in between the two transverse forces, we are having some ligament, intertransverse ligament, and intertransverse muscle. Intertransverse lateralis muscle. Intertransverse lateralis muscle is this one. Intertransverse medialis muscle is here. So just posterior to this transverse process and the intertransverse tissue complex, we are having the erector spiny group of muscles. And if you wish to do a erector spiny block, then your needle should be resting over here, over the transverse process. And if you're going anterior to this intertransverse tissue complex, intertransverse tissue complex means this ligament, the muscle, and some of the other neuromuscular bundles. Anterior to that is your psoas muscle. And within the plane of the psoas muscle, so you might be able to see the ventral rami of the lumbar plexus. So if you wish to do a lumbar plexus block, you need to find out that plane within the psoas muscle where you can do the lumbar plexus block as well. So now this is the MRI, what I was telling, that this transverse process. So you look at here, transverse process. So this is making the three very clear, distinct. Anterior to that transverse process is your psoas. Posterior to this transverse process is the erector spiny, and lateral to that, this one here it is red, is your quadratus muscle. So quadratus muscle is basically a thin layer of muscles, sandwiched between the two layers. One is psoas anteriorly and erector spiny posteriorly. So this was an MRI pictures. Now coming to the probe. Mostly we use the curvilinear probe because lumbar spine is deep. Normally something around the 5-6 centimeter till the 12 centimeter depth is needed, and which can be done by the low frequency curvilinear probe. But when you are seeing the superficial structure like supraspinous ligament, then your linear probe might be helpful. And positions are lateral decubitus, patient might be lying, lateral decubitus, patient might be sitting. Today I'll be demonstrating it in the sitting posture. Sitting posture is comfortable for the anesthesiologist, and sitting posture is another advantage is you can bend forward, ask the patient to bend forward so that the two spinous processes get separated and you can see the spinal canal nicely in the sitting posture. Otherwise, if you're doing under the prone posture, that is also acceptable. Particularly for the pain physicians, prone posture is important. It is almost similar to that of the sitting, but here you need to put a pillow under the lower abdomen so that your lumbar lordosis is corrected and it becomes, little bit more flexed, so that you can have the good space between the two lamina or two spinous processes. Now, position of the probe. Position of the probe can be your median sagittal over the midline, sagittal. Paramedian sagittal comes little bit side of the midline, or it can come little bit of paramedian sagittal oblique, means it's similar to that, but here we are tilting the probe little bit more towards the midline. And transverse is two. One is over the transverse spinous process, another is in between the two spinous process, where you can find the gap between the two spinous process and we can see inside the spine. So the identification of the structures, identification of the level. So normally this is the home page view. We call it home page view, where the probe is over the transverse process. It is approximately 3 centimeter or 3 to 4 centimeter from the midline. We are holding the probe, and if you are holding the probe here, we'll be able to see this transverse process very nicely. So this is the hyperechoic structure, transverse process, and in between the two transverse processes, we'll be able to see the ITC. ITC is not Indian Tobacco Company. ITC is your intertransverse tissue complex. So where there is intertransverse ligament, intertransverse lateralis muscle, and neuromuscular bundles. And anterior to that ITC is your psoas muscle. Posterior to that is your erector spiny group of muscles. So this is also called the trident view, like this, or you can call it, the finger-like projection. But sometimes you may not be seeing the 3 fingers together. You might be sometimes seeing the 1 finger or 2 fingers also. But these projections, the acoustic shadow through the psoas muscles will be telling you that your probe is now oriented in the sagittal view over the transverse process. Then when you'll be moving the probe little bit more medially, this is called articular process view. And here it is also called the camel's hump view because this is the articular process. So this is it looks like a camel's hump. So it is called the camel's hump view. So it is approximately 2 centimeters from the midline. And then we are having over the laminar view, or you call it the paramedian sagittal oblique view. So we are tilting it to see the spinal canal in between the lamina. So this is one lamina, this is one lamina, and in between the lamina, through the gap, the ultrasound beam goes in, and we can see the layers here, 2 layers here. So we call it as a posterior complex. So in the posterior complex, we are having the ligamentum flavum, we are having a small epidural space, and we are having the dura. So you can see these 3 structures: dura, ligamentum flavum, and in between the two layers, there is a hypoechoic areas, and together they are called as a posterior complex. And anteriorly, you are having the anterior complex. So what are there? Anterior dura and the posterior longitudinal ligament and the hyperechoic side of the posterior cortex of the vertebral body. So these together are also called the anterior complex. Posterior complex are mostly distinctly seen. 2 hyperechoic lines are distinctly seen, like here you can see it, one layer, another layer. Anterior complex normally not that distinctly seen. The 3 layers may not be seen properly. The together is called the anterior complex. But posterior complex mostly will be seeing the 2 hyperechoic line. And if you are, your needle should be coming in between these 2 hyperechoic lines, the hypoechoic area, epidural space, your needle should be coming there. And this is also called the horse head view because it looks like a head of the horse. Counting, we can see that sacral bones means they are continuous. Suddenly, when the first break will come, it will be L5 S1 level. Like sacrum you are coming, it is continuous because they are fused, and then the break will be coming, that is L5 S1, and then that way you can go on. You can also count over the spinous process. So in the midline also you can count. First break what will be coming will be your L5 S1. So now in the transverse view, when we are putting our probe over the spinous process, what will happen? Spinous process is the bone, so you can't see anything beyond the bone. So you'll be having the 3 steps. First step is spinous process, next step is lamina, and next step is transverse process. So there are 3 steps. And if you wish to do the medial branch block, we'll be doing block to the needle here. And as I was telling, we'll be able to sometimes, not always, the artery. Normally, the medial branch, the accompanies one artery here. So you'll be able to identify that. And in this view, if we're tilting a little bit anteriorly, posteriorly, we might be sometimes able to see the plane between the psoas for the lumbar plexus. So this is the interspinous space view. So this is also called bat's view, because it looks like a bat. So this is the interspinous ligament through which the USG beam is going down. So this is posterior complex, this is anterior complex, in between is the interthecal space. We can see the facet joint here, and we can see the transverse process here. So this is one where normally, if you wish to do the spinal epidural, this is not the view, but you can have a clear idea about where is how deep is the posterior complex, how deep is the anterior complex, so that when you are doing a procedure, you'll be having a clear idea how to reach and where not to reach. So this is another, I'll be showing you, this is our own Daradia's technique. So foraminal view. Through the foramen, we can see the structures in the foramen, and even through the foramen, you can see the disc as well. So what we do here, after the home page view, we are putting the probe here with the 2 transverse processes. Then when we'll be going more medially, we'll be in the articular view. One will be here, another will be here. Now, keeping the distal end fixed, we will be taking back the proximal part here over the transverse process. And this will be more superficial, this will be deeper, and through which we'll be able to see the foramen, we'll be able to see the nerve root, we'll be able to see the pulsating blood vessels accompanying the nerve roots, and also some of the USG beam, some of the ultrasound will be going deeper into the disc. So this is foraminal view I'll be showing. So see how I'm holding the probe. So I told you home page. So this was the home page. See how I'm holding the probe. It is approximately 3 centimeters from the midline. And here, so this is the finger-like projections. So these are the transverse process. how you can see here, please. Okay, so these are the transverse process. What I was telling that, okay, we may not be able to show all the transverse process together, 3 transverse process together, but here this is the one of the transverse process what I have kept here. Another is here, another is little bit here, and you can see there is the acoustic shadow going down, going down, going down, and what you can see else here. So in between the transverse process, you can see that layers. This is your intertransverse complex, or intertransverse tissue complex. So what is there? So here we are having the intertransverse ligament, intertransverse lateralis muscle, and the neurovascular bundle. And this is your psoas. Psoas. This is your erector spinae. At this laterally, most likely this is your iliocostalis muscle, because that is the most lateral muscle. And quadratus we cannot see here because we are over the transverse process. If you are going little more laterally, then you can see the quadratus. Okay. So first, from this position, I'll be going from these positions. Okay, I forgot to mention one thing, that my aspect marker is towards the cranial side, proximal side. That means the left side is your proximal side, and the right side is my distal side. Okay, I forgot to mention this. So this is your transverse process view, home page view. We normally start scanning from here. And you can see after the psoas, the peritoneum is moving below the psoas. And if you can see, another very important thing is depth of the psoas muscle and the thickness of the psoas muscle. If you are going more proximally, the depth is less. And if you are going more distally, so it is. So here you can see this psoas is like this. That means here the depth of the psoas is less. Here the depth of the psoas is much more. You see the peritoneum is moving, peritoneum here and here. So this is again important, that the psoas depth or thickness of the psoas muscle is less as we are going more proximally, upper lumbar area. And if you are going deeper, lower lumbar, then the psoas is thicker. So from this position, what I am doing, I am going more medially. And you see what is happening. So if I'm going more medially, you see here transverse process, and now see some bone is appearing. See, these are the bone appearing. Bone appearing. So look at there, what is happening. So here it was only transverse process, and now these bones are coming. These bones are coming. These are what? This is the mammillary process of the superior articular process. Superior articular pillar, so there the mammillary process first appears. And then if I am going little more, then transverse process is vanishing. And now what we can see is this is called the articular process view or Camel's hump view. Okay, so this is your Camel's hump view. So you can see here it was, see, this was your transverse process view, and here now the articular process is starting. So this is your articular process view. Clear? So these are the articular processes or Camel's hump view. And now I am going more medially. Your articular process view, and now I am coming more medially. So now what is happening? So now we are having the laminar view. And here is, okay, this is also called the horse head view. You see, this is looking like a horse head, and through which the gap, this USG beam is going in. So this is your posterior complex. You can see the two layers very distinctly and the hypoechoic area in between. So ligamentum flavum and the dura, and the anterior complex. So where we are having the anterior dura, posterior longitudinal ligament, and the posterior cortex. And in between the black area is your interthecal space. So if you wish to do the ultrasound assisted, the spinal epidural, so this is how we should be doing. Again, this was, I started from here. So this was our transverse process view. I'm going now, the bone is started appearing. That is your articular process view. So you see here the articular, this bone is starts coming, articular process view. And now this is articular process. And now if I'm tilting it, so this is your horse head view. This was your home page, transverse process view. And now look at what is happening. So I told you at this level, we can see the intertransverse tissue complex. So at this level, what I was telling, that this was your intertransverse tissue complex, and this is your erector spinae, and this is your psoas. So now, if I'm moving the probe laterally, then the thoracolumbar fascia will come, and then it will be splitting, thoracolumbar fascia will be splitting, and the two layers. So I was here, and if I'm going lateral, you know what is happening. If I'm going laterally, see what is happening. So transverse process tip is seen, but what is important here, you see these two hyperechoic line, they are basically the two layers of the thoracolumbar fascia, anterior and the middle layer of the thoracolumbar fascia. And the muscle which is appearing now is your QL muscle, quadratus lumborum muscles. So now, again, look at this carefully. So I was in between the two transverse processes. You can see. So now I am going laterally, transverse process is vanishing. Now the thoracolumbar fascia is appearing. Now if I'm going more laterally, you see, so now we can see distinctly, please. So what we can see now? Now the two layers of the thoracolumbar fascia is very distinctly separated. And this is your QL muscle. And this is your erector spinae muscles. And this is your psoas muscle. So these are the three distinct layers of the muscles which you can see here in between the thoracolumbar fascia. QL, posterior to the thoracolumbar fascia is erector spinae, anterior to the QL muscle is your psoas. So foramen is between the two pedicles, one pedicle, another pedicle. Foramen is here. If your needle is going above, upper part of the foramen, we call it septriangular approach, or we also call the subpedicular approach, because here our needle is just below the pedicle. And there is another approach which is called the Camel triangular approach. There our needle will be lower. So there are the two important approaches. Here, what I will be showing you, my needle will be coming like this, above the transverse process. So our needle trajectory will be coming like this, above the transverse process and coming into the at this angle. Means little bit oblique, and over the transverse process and below the articular process, superior articular process. So now see how we are doing. Home page view. So we are over the transverse process, and I am just slowly, let me keep slowly. So here, transverse process, I'm slowly going towards the articular process view. So here, transverse process, and I'm slowly going to the articular process. So here, the articular process. So at this point, articular process, what I'm doing, I am just making my, you see, look at my probe. So what I'm doing, I am tilting my probe, proximal end of the probe, back to the and superior other pole into the articular pillar. So now what you can see here, so you just look at the arterial pulsations. So this is the nerve root, hyper and hypoechoic. This is the nerve. So this is your. So let me draw it here over in the live scanning. So this is your transverse process. This is your superior articular process, mammillary process. This is your nerve root. And you can see the pulsating blood vessels here and here the blood vessels. I'm just putting it here live because you can see the pulsating blood vessels in the foramen. So this is the foramen, also going through into the disc. So just anterior to the foramen is your disc. Again, I'm showing you from the beginning. Beginning means home page. So you'll be starting from here. So this is your transverse process view. So now I am going medially. If I'm going medially, what is happening? If I'm going medially, we can see the articular process view. So here I am keeping two articular processes here. And now what I'm doing, at this point, you cannot see the foramen nicely. Now what I'm doing, I'm tilting the probe proximal end back to the transverse process. So now the proximal end of the probe is back to the transverse process. It is deeper. So you can see the two hyperechoic area. So this is your transverse process.
and this is your articular process. And I am tilting, making my probe little bit oblique. So at this point, can you please? Okay. So at this point, what are the structures you can see? This is your superior articular process. Bony part, that's why this is casting an acoustic shadow. This is your transverse process, and this is the foramen. So here is the nerve root, and in front of that, this was the pulsating blood vessels. Some other small, tiny blood vessels are there, but we are more concerned about the blood vessels, which is just anterior to the nerve root. So what we can do here, we can put the needle here. This is the lower part of the foramen. This is the upper part of the foramen. So normally, when we are putting the needle here, then this is called the subpedicular approach. But here in plane, you cannot do that. Here you can do it only by the out of the plane. But here in this technique, we can do the in plane block. Means our needle will be coming here like this. So needle will be coming here. So in that patient, you can look putting it. See, I was tilting my probe like this. That means needle will be coming from here over the transverse process. That means over the transverse process here, and then the transverse process view, then going back into the articular process pillar view, and then tilting the proximal end back to the transverse process. And now this is your foramen. So this is your foramen. You can see the nerve root there, and also see the pulsating blood vessels there. These are blood vessels anterior to the nerve root. See here, this one, and also some blood vessels in the lower part of the foramen as well. So foramen, remember, lots of blood vessels are there, and this is your nerve root, hyper and hyper. So this is how you can see the foramen, and also the ultrasound beam is going down through the disc, because the foramen, lower part of the foramen, is going if you are putting a needle, it will go into the disc. So this was the sagittal scanning. Now we'll be doing the transverse scanning. So if I'm doing the transverse scanning, I told you, one, I'll be over the spinous process. So here I am over the spinous process, and in the spinous, why I'm over the spinous process? Because I can't see anything between and this is between the two spinous processes. Why? Because this, we can see the anterior complex. This is the anterior complex. So the USG beam is going down, but here I am over the spinous process because I can't see anything. Okay, somebody was asking about the three muscles. I'm tipping these things here. Okay, so here are the three muscles we can identify. So this is the most medial one, is your multifidus. Then this is your longissimus, and this part is seen is your iliocostalis. So these are the three muscles. Together, these are the erectospinal muscles. Then anterior to that, we are having the psoas muscles here, and here in narrow is your QL. Okay. I'll be showing you again all these three muscles nicely. You just keep in your mind about the anatomy, and then look at here again. So, okay. So here I'm over the spinous process, and if I'm going laterally, we can see the three nice erectospinal group of muscles, and lateral to that we are having the this part is your QL. This is one layer of the thoracolumbar fascia. This is another layer of the. So this thin layer of the Q is their QL, and this whole is your psoas. This is your lamina. This is your transverse process. So here we'll be trying to find out if you're doing the medial branch block, then needle should be coming here. So this is your transverse process, and now see very nicely seen here the pulsations. Everybody can appreciate that. Can you appreciate the dancing arteries? Say yes. Can you? Just in front of my pen, over the transverse process.
Yes,
can you see the pulsation? Yes. And just beside that is your nerve. So if you wish to do the medial branch block, your needle should be coming like this. Your needle should be coming like this, in plane approach. Okay. So now, when we are in between the two spinous processes, so what will happen? We will be able to see the anterior complex. So this is also called the Bat's view. And here you can see, this is your lamina. This is your facet joint. You can come and inject facet joint here. So here at the edge of the lamina, where the lamina is ending, this is your transverse process. This is your posterior complex. This is your anterior complex. So, and black area is your intrathecal space. Is it clear to everybody? So this is when we are peeping, looking through the between the two spinous processes. So again, I'm showing you, this is your over the spinous process. Here you can't see anything inside. And if I'm coming in between two, then what is happening? We are able to see. And over the transverse process, if you are minutely searching, you'll be able to see the one artery, which is accompanying your median bench. And now I'll be showing you. So see how I'm holding the probe. So here, okay. So what you can see here, this is your vertebral body. This is your aorta. See, I'm holding the probe. How I am holding the probe? My aspect marker means this side is the aspect marker. This is anterior side. This is your posterior side. This is anterior side. And I'm holding the probe here. This is your vertebral body. This is your aorta. And this is your spinous process. You see, when I'm tilting the probe, sometimes the spinous process is vanishing. Let me clear. Keep this orientation nicely. So see, now transverse process is coming. So this is your transverse process. Here transverse process, I am swinging it from the lateral. So it comes, closer to your, the probe. So this is your transverse process. This is the vertebral body. This is your aorta. And what is this muscle? This muscle is your, which muscle is this?
Quadratus.
This muscle. This is posterior. This is anterior. This is lateral. This is your spinous process. Anterior to the spine, the transverse process. Anterior to the transverse process is which muscle? Psoas, very good. Quadratus is here. Quadratus is here.
Quadratus, the flag.
Okay. Quadratus is lateral to the spinous process. You see the spinous process. This is your QL. And what is this muscle?
Erector spinae.
Erector spinae. Very good. So if you wish to do the lumbar plexus block, your needle should be coming in this plane within the psoas. If you wish to the QL block, your needle can be here, your needle can be here, because QL block is having the separate anterior, lateral, and the posterior to the QL. And if you wish to the erector spinae group block, so then your needle should be over the spinous process here. Transverse process here. So these are the different kinds of block. These are also important for us as a pain physician also. We get the psoas myofascial pain, erector spinae myofascial pain, pure tratus lumborum myofascial pain. These are the things what we do also by as a pain physician. Okay, now another very important thing. This is also important for the pain physicians. Okay, so see, once you are able to see the transverse process very nicely, these are transverse process. Look at here. And when I'm tilting the probe, sometimes it is going away. You see, now it has gone away. And now it is coming. Now it is gone away. So now when it is coming away, now look at this area very nicely. This is the foramen. In between the two transverse processes is your foramen. And you see there, you'll be able to see the pulsations there. Very minutely look at there. You can see the pulsations and you can see the nerve roots also there. Nerve roots are coming from there. So if you wish to the transferable, this is another approach to do the transferable. This is the posterior side, you can come like this. If you wish to do a lumbar sympathetic block, your needle should be coming like this. If you wish to do the rami communicants block, your needle should be coming like this. So these are the different other pain procedures what you can do. See, again, I'm showing you. So what you are doing, you are putting, this is over the transverse process, transverse process, right? This is the transverse process. This black area is the transverse process. And when I'm tilting the probe, the transverse process is going away. Transverse process is going away. And now you can see the foramen. And these are the areas of the spinal canal. So this is the foramen. And you can see, even you can see the disc, through the disc. Vertebral body, when it is through the disc. If it is vertebral body, the acoustic shadow, there will be acoustic shadow. You cannot see anything there deeper. But if it is within the disc, you can see the USG beam is going down. And this is the area where you can do all those things. So this is over the transverse process, and this is in between. And you can see this is the foraminal area. Okay, so that completes the lumbar spine scanning.
So there was a question for you. Where do we
Yes.
deposit the local anesthetic for lumbar plexus?
Lumbar plexus I have shown you, where again I am showing you. So how do you have to identify? How do you have to identify is that you identify the psoas. So this is your psoas. And lumbar plexus, ventral rami, lumbar plexus is our target. So you see there is a plane which is going down here. You know, so this is the area where it should be. So needle should be coming posteriorly like this. And if you are holding the probe like this, you can easily see the needle very nicely, because the needle will be almost horizontal to the beam. And this is the area where. So very important is you have to identify the psoas very nicely in this view. So if you can identify the psoas very nicely, then you can do it. Okay, so hold the probe like this, see the transverse process, and in between the transverse process is try to find out the psoas. When you're seeing the psoas, try to find out the cleft, a layer through which the ventral rami goes and come here. Normally it is anterior 1/3 and posterior 2/3.